Dr. Shubhendu? Dr. Shubhendu, am I audible?
Hello. Are you? Am I audible to you?
Yes, sir. Yes, sir. You're
Yes.
audible. Sir,
Okay.
can we have a
Okay.
brief
Myself, Dr.
history?
Anshul Agrawal from second OT, second case.
Yes, sir.
So you have to zoom here. First, this image. So we can see the MRI of our 60-year-old female patient having left side radiculopathy, pain more in walking after 10 to 20 minutes, pain radiate to the left lower leg up to knee and increases after walking some steps. No pain in initial walking and patient is not having any back pain, though she is having mild dystosis, but it is stable on dynamic X-ray. So we can see the lesion at the last mobile disc.
So we cannot see the
L4-5.
MRI.
L5 is sacralized. So we are now getting the axial images of the same patient. We are removing the X-rays from here. ये लगाना भाई, X-ray पकड़ो एक जना. So we will target this disc, this axial area, and our target is to free the left side traversing nerve root and opposite side traversing and exiting nerve root. So this is the left side area which we will address at first go, and this is the contralateral area which we will address after decompression of the ipsilateral side. So we will start soon. Our preparations are going on. You can show there. Dr. Shubhendu is ready for his armamentariums. Some are coming, some are placed. We placed a craniotomy drape over the patient. Patient is under spinal anesthesia, prone on the customized bolster, and patient is conscious, don't show the face. So we have taken the camera ET off, but for water protection we have put the camera cover over it. It is not needed in many hospitals, and some hospital prefers to cover the camera. So our drill setup is ready over here. We can see the blue one, mechatronic drill is there, endovision plasma and radio frequency attachment is there, and whole Karl Stos console is ready for the endoscopic procedure, and we are ready with the flat panel C arm. We will land on the left side, L4, L5 spinolaminar junction, L5 is sacralized. We have to remember that L5 is sacralized and we are operating the L4, L5 level from left side ipsilateral and right side contralateral. This is the posterior stenoscopic lumbar decompression procedure. So any questions from your side? Audience want to ask something, or anybody can coordinate from the audience side? We can take few questions till we starting.
Any questions from the audience? So, yes. Sir, Anshul sir, I'm Dr. Saujanya, moderating from the house. Am I audible, sir? Anshul sir? Dr. Shubhendu? Ranadi. So in the meanwhile, sir was speaking about sacralization, right? So ideally for any MIPSI procedure of the spine, or in fact for anything else, first what is important is we always know our target. So most of the times, at least in about 30 to 40% of the procedures that we do, most of the times we either see either a lumbarization or sacralization of the spine. So if you are not aware of it, correlating it with the MRI and on the table, if you don't correlate it with fluoroscopy, we might actually be going and doing our MIPSI intervention in the wrong level. So it's always, we yeah. So sometimes we might not know whether it is a lumbarization or sacralization. So how do we know what level are we operating on? Very simple. Look at your MRI. From in the MRI, which is the last level of the disc that is there. So from that disc, count upwards what is the disease disc, and on your fluoroscopy also look at what is the last disc, and based on that you will be able to target your MRI and your the disease disc in the fluoroscopic image. So it's always good to have a knowledge of the lumbarization and sacralization.
Can you ask the question again?
No, sir.
Anybody wish to?
No,
Yes, sir.
no, we haven't asked any questions, but we just wanted to know if you're audible or not.
Audible.
Okay, sir. Okay, sir. So, a brief history of the patient as to why endoscopy is needed in this patient, sir.
Actually, patient is having claudication after walking 10 to 20 minutes in left side leg.
Okay. So, your experience in doing these endoscopic procedures in local anesthesia with caudal analgesia, sir?
Yes, it is very good if it is done in caudal analgesia, not in caudal analgesia, it is sensory epidural. Oh,
So,
okay. It can be done in sensory epidural or spinal anesthesia. So posterior procedures are safe in GA or spinal, or although in sensory epidural, but patient sometime moves in sensory epidural, so it is difficult to make him prone for very long duration. So nowadays spinal anesthesia is equally safe for these patients.
okay, sir. So, most of us, I mean, doing endoscopic procedures, we have moved towards from giving anesthesia to going towards, I mean, we do these procedures under local anesthesia itself, and
Yes. With time we can move on the spinal anesthesia for posterior stenoscopic lumbar spine decompression. Especially, we can do disectomies in local and sensory epidural, but it is better in my experience that if we can do in spinal anesthesia.
okay, sir. Thank you. So earlier